I'm Catherine Santoro, Director of Policy and Development at the National Institute for Healthcare Management Foundation, and on behalf of NIHCM Foundation, welcome to our webinar today, The Opioid Crisis, Understanding Pain and Preventing Opioid Misuse. Every hour, more than 4 Americans die from opioid abuse, and nearly half of opioid-related deaths involve legally obtained prescription medications. To explore efforts to prevent opioid misuse and promote appropriate pain management, we're pleased to have a prestigious panel of experts with us today. Before we hear from them, I'd like to thank NIHCM's President and CEO, Nancy Chalkley, and the NIHCM staff who helped to convene this event today, including Caitlin Ellis, Katie McDonald, Carolyn Myers, and Kirsten Wade. You can find biographical information for all of our speakers, along with today's agenda and copies of slides on our website. We also invite you to live tweet during the webinar today using the hashtag #OpioidMisuse. I am now pleased to introduce our first speaker, Dr. Christina Mikosz, a medical officer on the Opioid Overdose Health Systems team in the Division of Unintentional Injury Prevention at the Centers for Disease Control and Prevention. She joins us today to share CDC's efforts to prevent opioid misuse and overdose. Christina?
Thank you. Good afternoon, everyone, or good morning, depending on where you're calling in from. It's a pleasure to be here today, and I appreciate having the opportunity to speak to you about this important topic. The United States, as we know, is in the midst of an opioid epidemic, which was driven initially by the overprescribing of opioid pain relievers in the treatment of chronic pain. However, more recently, we've seen a sharp rise in heroin-related and now fentanyl-related overdose deaths in a new but not entirely unrelated development in an epidemic that's really touching every corner of the country. I'm going to spend a few minutes outlining in detail the data underscoring the public health burden, and then I will spend a few minutes discussing CDC's public health approach to prevention, specifically highlighting a few of our signature initiatives. Overall, drug overdose death rates have never been higher, and we know that over 6 out of 10 of these deaths involve opioids. Through 2015, almost 310,000 people died from overdoses involving opioids, prescription or illicit, in the United States. There were a number of factors that led to the current epidemic. To name a few of them, there was a history of pain being designated as the 5th vital sign, an underappreciation of the addictive potential of prescription opioids, aggressive marketing of these drugs to clinicians, just to name a few of these factors. This is one epidemic, but there really are 3 waves of it. And we like to think of the prescription opioid epidemic as priming the pump for the subsequent waves in some ways. And so that the rise in heroin, illicit, fentanyl-related deaths also have distinct features too. The first wave of the epidemic was prescription opioids, and the toll from this is still high. Through 2015, over 183,000 people died from overdose involving prescription opioids in the U.S. In 2015, we lost over 40 Americans every day to prescription opioids. Deaths related to natural and semi-synthetic opioids, which is the grouping that includes the most commonly prescribed opioids, oxycodone and hydrocodone. That's represented by the purple line on this graph. That increased 4-fold between 1999 and 2011. Prescription opioids continue to be involved in many overdose deaths. The death rate due to methadone increased 6-fold in just 8 years between 1999 and 2007. It's decreased substantially since then. That's the good news. But methadone is still involved in a lot of deaths relative to the amount that it's prescribed for chronic pain. So to put some numbers to that, in 2014, methadone accounted for 1% of prescriptions for pain relievers, but was involved in 23% of opioid-related deaths. I want to spend a few minutes focusing on the prescription opioid piece, since it really is what sounded the alarm for this epidemic. We know that chronic pain is common and that treatment can be challenging for healthcare providers. We define chronic pain as pain that typically lasts more than 3 months or past the time of normal tissue healing. Recently, data analysis showed that there's an estimated prevalence of daily pain of around 11% of the adult population. And to put that number into perspective, that's more than the 9% of Americans diagnosed with diabetes and about the same number as Americans with diagnosed heart disease. We also know that opioids have been frequently prescribed for this pain. An estimated 20% of patients presenting to physician offices with non-cancer pain symptoms or pain-related diagnoses, including both acute and chronic pain, receive an opioid prescription. And that's notable because primary care providers have reported concern about opioid pain medication misuse. They find managing patients with chronic pain stressful. They have expressed concern about patient addiction and report insufficient training in prescribing opioids. I've listed a few common prescription opioid pain relievers here. So that includes hydrocodone, oxycodone, oxymorphone, fentanyl, and methadone. Who's at risk for overdose? We know that as the dose goes up, the risk also goes up, both when opioids are taken for acute and chronic pain. Following a case cohort design and using a large data sample from the Veterans Health Administration, this research group showed that among patients receiving opioid prescriptions for pain, higher opioid doses were associated with increased risk of opioid overdose death. For those patients on a maximum prescribed daily dose above 100 morphine milligram equivalents, or MME, there was a 7-fold increase in death. And even for those patients in the lower range of 50 to 100 MME, the risk was still almost 5-fold. And as we've learned more about these risks over time, existing evidence-based prescribing guidelines have continued to lower cautionary MME thresholds from 200 to 120 to 100 to even lower. A majority of patients who have died from opioid overdoses had multiple sources of prescriptions and/or high dosages of opioids. In this graph, the gray sections of the bar represent those patients with fewer prescription sources and lower opioid dosages, while the blue sections represent greater than 3 prescriptions or high dosages of opioids over 100 MME. As you can see, only 6% of control patients had multiple prescription sources or high dosages, but a full 55% of those who had a fatal overdose met those criteria. A central premise leading to the proliferate use of prescription opioids was the argument that if they were used properly, they would not lead to addiction. But there's an increasing body of research that's debunking that myth, especially when you're talking about a high daily dose taken for greater than 90 days. Using data from a large medical claims database, this research group showed that patients on a long duration and high dose opioid prescription, defined as over 90 days at greater than 120 MME, they had a 122-fold increase in the likelihood of being diagnosed with an opioid use disorder. And I just want to pause to put that number into context. 122-fold. So the odds ratio for lung cancer in current smokers relative to non-smokers has been estimated at 40. And that's a well-understood, well-established medical relationship. And the odds ratio for heart disease in current smokers relative to non-smokers has been estimated at 2. And even at lower doses of 36 MME or lower, there was still a 15-fold increase. We're at a point where as many as 1 in 4 people taking long-term opioids for chronic pain in primary care settings struggles with opioid use disorder. Turning back to the graphs of the epidemic, the second wave of the opioid epidemic is heroin. Heroin is available in larger quantities, used by a larger number of people, and is causing an increasing number of overdose deaths. The heroin-related death rate, which is the orange line here, has increased 4-fold since 2010 through 2015. Nearly 13,000 Americans died from heroin in 2015. And the third wave in the opioid epidemic is fentanyl. Fentanyl is up to 100 times more potent than morphine and 50 times more potent than heroin. Its primary use is for managing acute pain or chronic pain associated with advanced cancer. It's extremely fast-acting. And although prescription fentanyl can be diverted for misuse or abuse, most cases of fentanyl-related morbidity and mortality have been linked to illicitly manufactured fentanyl when it's laced with heroin. The death rate for synthetic opioids, excluding methadone, has more than tripled over the past few years, and over 9,500 Americans died from synthetic opioids in 2015 alone. We are now at a point where in 2015, Americans lost 2.5 months of life expectancy due to opioids. This really underscores the seriousness of the opioid overdose epidemic, as we don't tend to see losses of this magnitude attributable to a single cause in the U.S. The last time was in 1993, attributed to HIV/AIDS. 2016 forward-looking data wasn't available at the time that the analysis that I'm showing here was performed, but life expectancy in the U.S. has now decreased 2 years in a row because of opioids. The last time there was a 2-year decrease in the U.S. was more than half a century ago. So I'd like to transition to the CDC's response to the opioid overdose epidemic. At CDC, we have 5 priority areas to address this crisis, which complement the work of others across the federal government. They are to improve data quality and track trends to monitor the epidemic, strengthening state efforts by scaling up effective public health interventions, enhancing patient safety by supplying healthcare providers with data, tools, and guidance for evidence-based decision-making, empowering consumers to make safe choices, and coordinating with public safety and community-based partners to rapidly identify overdose deaths, reverse overdoses, link people to effective treatment, and to reduce the harms associated with illicit opioids. In September of 2015, CDC launched the Overdose Prevention in States Initiative to help state work, given that it's states that regulate health professions, they run prescription drug monitoring programs, or PDMPs, they're the ones administering large public insurance programs like Medicaid, and they have the public health surveillance capacity to track the epidemic. A total of 45 states plus Washington, D.C. are being funded via our Prevention for States, Data-Driven Prevention Initiative, and enhanced state opioid overdose surveillance programs to support state-level resources to report non-fatal and fatal overdoses more quickly, identify risk factors for fatal overdoses, enhance PDMPs, sharing data to improve multi-state surveillance, among other strategies. To better equip healthcare providers with evidence-based guidance, in 2016, CDC finalized an opioid prescribing guideline for primary care providers to treat chronic pain outside of active cancer, palliative, and end-of-life care. A guideline was needed to better align opioid prescribing practices in primary care settings with the best available evidence to ensure safe, effective pain management, as research has shown that primary care providers prescribe the most opioids. The guideline's not a rule, it's not a regulation, it's not a law. The guideline's not intended to deny access to opioid pain medications as an option for pain management. It is intended to inform clinicians' discussions with patients and their prescribing decisions based upon the best available evidence about benefits and risks of opioid use. There's 12 recommendations in this guideline, including guidance recommending that opioids are not the first line of routine therapy for chronic pain, using caution when increasing dosages, especially more than 50 MME or MME per day, or to avoid or justify escalating the dosage to 90 or more MME per day. Not needing more opioids than needed for acute pain. 3 to 7 days is felt to typically be enough. Checking PDMPs for other prescriptions and to assess for high total dosages. Avoiding concurrent benzodiazepine and opioid use. And offering or arranging medication-assisted treatment for opioid use disorder. A lot of work went into making sure that we got this guideline right. But of course, the success of the guideline hinges on our ability to effectively disseminate that information and to get it out there into the hands of those who need it to move forward. And to that end, we've identified 4 priority areas to maximize uptake and use. This includes translation and communication, clinical training, health system implementation, and insurer and pharmacy benefit manager implementation. So I'm going to walk through this in a little bit more detail. On our translation and communication efforts, we've created this easy-to-follow checklist or algorithm about the CDC guideline, as well as a number of other fact sheets for both providers and patients, which can all be found on our website. We also released a mobile app for Android and Apple devices that includes prescribing guidance. It's based on our prescribing guideline. It has an MME calculator and motivational interviewing tips for prescribers when talking to patients about opioids and opioid-related risks. Within education and training, CDC partnered with the University of Washington to present a webinar series about the CDC guideline. 7 one-hour webinars are available for free online for CME. They can be accessible at the link at the bottom of the screen. And we just launched the 4th in a series of interactive online trainings for healthcare providers, shown here on the right. These trainings feature the recommendations in the guideline, providing sample scenarios, feedback, and resources, like conversation scripts for discussing opioid use with patients. This and all future trainings will be available for continuing education credit. Healthcare systems have the potential to improve pain management, including safer use of opioids through guideline-concordant care on a broad scale. To name a few activities to assist health systems in this area, we've created a clinical quality improvement technical package to help health systems develop processes and deploy strategies to facilitate adoption and use of the recommendations. This contains guidance such as identifying organizational champions, providing trainings on guideline communications, and mechanisms to provide auditing or feedback cycles to monitor progress. We also work to update clinical decision supports to integrate recommendations into electronic health records. So some examples of what might fall into that area are alerts when someone's about to prescribe something that might exceed a patient's MME threshold, defaults on prescribing amounts to when initiating opioids, prompts to check the PDMP. There's a few examples. We've also developed and piloted a coordinated care plan, providing primary care clinicians, practices, and health systems with a resource to implement structured and coordinated opioid therapy for patients with chronic pain. We're also working to better understand the effectiveness and the adverse effects of non-pharmacologic and non-invasive treatments for chronic pain. If we're saying that opioids should not be the first-line choice, then what should be? CDC is working with the Assistant Secretary for Planning and Evaluation in HHS and the Agency for Healthcare Research and Quality, or AHRQ, to support an evidence review of the literature. And this evidence review is focusing on the effectiveness and adverse effects of different non-pharmacologic, non-invasive therapies for five diagnoses: chronic low back pain, chronic neck pain, osteoarthritis, fibromyalgia, chronic headaches compared with non-opioid pharmacologic therapy, opioids, and other non-pharmacologic treatments. This review is in the final stages, and the report will be available to the public within the next few months. Private and public insurers and pharmacy benefit managers can also foster guideline implementation through improvement in coverage and service delivery payment models and proactive use of claims information. Some priority interventions that can facilitate guideline implementation include coverage for non-pharmacologic treatments like exercise therapy and cognitive behavioral therapy, removing barriers to prescribing non-opioid pain medication, reimbursing for pain management. We know that visits to discuss coordination for chronic pain treatment can be quite labor-intensive. We support the coverage of patient counseling, coordination of care, and review of PDMP data. Promoting more judicious use of high dosages of opioids, including drug utilization review and prior authorizations, and increasing access to evidence-based treatments of opioid use disorder and eliminating barriers when it's available. And it's critical for insurers to implement payment models that improve access to interdisciplinary multimodal care. Has made it a priority to raise awareness about the risks of prescription opioid use, and last year released an evidence-based consumer-directed communications campaign to empower consumers with knowledge to help them make safe choices. The goals of this campaign are to increase awareness and knowledge among Americans about the risks of prescription opioids, and to increase the number of people who avoid non-medical or recreational use or medical use of opioids for pain management. CDC incorporated first-person stories into this public campaign, featuring individuals living in recovery, individuals recovering from opioid use disorder, and family members who have lost someone to prescription opioid overdose. I'll close here. Wanted to thank you again for the opportunity to speak today, and I look forward to your questions in the question and answer period. Thank you.
Thank you so much, Kristina, for your and for CDC's leadership on this topic and for sharing those recommendations on how public and private insurers can continue to be an important partner. Our next speakers are Tom Leyden, Director of BlueCross BlueShield of Michigan's Value Partnerships Program, and Dr. Michael Englesbe, who directs the Michigan Opioid Prescribing Engagement Network, or Michigan Open, and we're so pleased to have them with us today to share their efforts in Michigan.
Good afternoon, everyone. This is Tom Leyden, and I'm the Director of Value Partnerships Programs in Michigan. And briefly on Value Partnerships Programs, that is BlueCross BlueShield of Michigan's provider-facing quality improvement and transformation programs. And a little bit about BlueCross BlueShield, we serve about 4.5 million Michigan members and another 1.3 million members out of state. And I can tell you with absolute certainty, addressing the opioid epidemic is incredibly important to BlueCross BlueShield, and it has our organizational intention and commitment from our CEO on down. Michigan is really no different than what's going on in the other states. And the slides are going really slow. There we go. Really no different. You know, we've seen overdose deaths triple since 2012. In fact, Michigan is about 10 million residents, and in 2016, Michigan healthcare providers wrote actually 11 million prescriptions for opioid drugs, so enough for every Michiganian to have a bottle of about 84 opioid pills. So there are a variety of efforts that we're taking through BlueCross BlueShield, and there's 4 main strategies that we're working on. Fundamentally, the first is working with state and national public policy leaders. Additionally, we're working to provide financial support to build community efforts. Third, we continue our pharmacy and utilization management programs. But what I'm here to talk about primarily today is about how we empower the provider community through innovative partnership programs. So that said, it all starts with data. And again, these slides are slow. One of our main strategies is to provide meaningful and ongoing reports to the provider community. This slide just shows you 2 examples of reports that we've been providing for the last couple of years to physicians. One is regarding doctor shopping, and that's looking at any shopping that's occurring within 60 days, and these reports go out on a monthly basis to physicians. And the other is around the Triple Threat Initiative, which you may know of as the Holy Trinity or the Houston Cocktail. And this is looking at the prescription of these medications in a 90-day period of time. We provide these reports not only to the physicians, but to their larger physician organizations / health systems to create a bit of a push-pull. And we've seen some really nice successes with these programs, reduction in opioid pills used, or dispensed, reduction in fentanyl use, as well as reduction in our opioid expenditures. That said, there's still more work that needs to be done, and we have continued to look at our benefit and coverage limits. We actually just recently changed our morphine equivalent dosing for our Medicare Advantage population from 250 to 200, and that's expected to go down further over time. Additionally, we look to expand these MED limits to the commercial population this year. And just in February of this month, we changed our first filled day supply limits for short-acting opioids to go from 15 to 5 days in our HMO population, and we're changing that as well in the PPO population. And we continue to look at utilization management initiatives as well. Another strategy that we've utilized for years is utilizing the existing guidelines and recommendations by the national provider societies. This is just an example of some of the guidelines that are out there via the Choosing Wisely campaign, and we provide educational tools to help the physicians, their organizations, as well as pharmacists implementing these guidelines. Similar to other plans as well, we have a philanthropic mission, and just a few weeks ago we announced $500,000 in community partnerships to further advance our social mission for Healthier Michigan related to opioids. And again, also we work with legislators at both the state and the federal policy to advocate on behalf of our members as well as for provider organizations so they have the best tools available to help our members. So now I'm going to talk about what we do in Michigan that's a little different than what happens in many of the areas across the country. Our Value Partnerships program is a long-standing 15-year-plus program, and this program is really working with the entirety of our network population of providers, and it focuses on transforming care processes. And there's funding available to both hospitals and physician organizations that rewards improvement at the population health level. And the biggest takeaway I want you to hear about these programs is that these programs were all designed in concert with the Michigan physician community. So these aren't programs that BlueCross BlueShield develops and throws over a wall and lets the providers have at them. These really are provider initiatives that are developed painstakingly in partnership with the providers. The partnership is pretty simple. You have BlueCross BlueShield as a funder. You have the Michigan physician and hospital community as participants, and then you have BlueCross BlueShield supporting coordinating centers. Those are physician leaders and teams who lead these statewide initiatives, and in a couple minutes you'll hear from Michigan Open, who serves in this type of role. So there are two types of programs within BlueCross BlueShield. The first is in our ambulatory program. It's called our Physician Group Incentive Program. And through this voluntary program, we work with approximately 20,000 physicians, which constitutes about 2/3 of our provider network. And this program fundamentally works to transform primary care and specialist care. The foundation of our PGIP program is the patient-centered medical home, and that's a transformation and designation program that we've had in place over the last 9 years in development with the Michigan provider community. Over the course of the last 8 years, we've worked with the PCPs in this program to transfer them into PCMH, or patient-centered medical homes, and approximately 84% of our PCPs in our program are now receiving differential value-based reimbursement tied to increased quality, better utilization. And as you'll see on the next page, we have been increasingly interweaving a focus on opioids and controlled substances. Two such initiatives is we have an electronic prescribing of controlled substances initiative. And when we started this initiative about 2 years ago, the statewide utilization of electronic prescribing for controlled substances was about 6.5%. We just got data in last week that shows that we are now over 30%, and that's a 300% increase in the last 2 years, which is pretty admirable given that at the moment we don't have any state legislation requiring the electronic prescribing. That said, it is being proposed, so I wouldn't be surprised to see that come about in the near future. And then, as I mentioned, we have the patient-centered medical home program, which is a long-established program that really works to transform how the patient is treated by their primary care physician, the specialist. And we have incorporated e-prescribing capabilities into that program. And the strategy with both of these initiatives is to really put the money where it's needed, to incent providers to change the processes so they can do what they need to do to provide the best possible care. And then on the hospital side, we have a program called Hospital Collaborative Quality Initiatives, or CQIs. The CQI program is internationally recognized, and in fact, AHRQ recognizes this as one of the national best practices out there. The CQI program is a statewide collection of clinical registries that for the most part collect information on every patient, their risk factors, their procedural information, as well as their outcome information. And the CQI program is built on the concept that physicians need better data. And fundamentally, traditional performance measures don't address areas of care which are highly technical, rapidly evolving, or scientifically uncertain. So through these clinical registries, we are able to collect data across the entirety of the state, the population of providers who perform specific services, and look to find links between the processes of care and the outcomes of care and implement best practices. The CQIs address a variety of clinical areas, including knee and hip replacement, bariatric surgery, spine surgery, et cetera. And just a little bit about the environment, because the environment here in Michigan is quite different. These CQIs, they meet for the most part on a quarterly basis, so that means you have providers driving across the state to meet for meetings that typically last between 4 to 6 hours. At these meetings, they are provided meaningful and actionable data that comes from the clinical registries. And finally, there are value-based reimbursement opportunities tied to improvement of goals. I can tell you, because I work on both sides of the fence, administrative data that a typical health plan uses to enact change only has so much impact because admin data doesn't have the robustness that physician community typically needs. The CQI data is audited, it's highly regarded, it's highly actionable, and it's really created a community here in Michigan where there's incredible sharing of data, incredible transparency around the data, and a sharing of best practices. And what that has done is created a highly engaged provider community. So my final slide before I turn over to Dr. Englesbe, I just wanted to give you an example of one of the CQIs and what they've been doing in the space. With our knee and hip replacement CQI called Markey, a couple of years ago, they actually had, I think it was first quarter of 2016, they had a quarterly meeting and they devoted their entire session to the opioid epidemic. They reviewed the data in their registries and the findings, and the data showed that patients who were presenting for surgery who were on doses of 50 plus milligrams of opioids had worse outcomes, increased complications, increased mortality. It was an incredibly robust day. You had surgeons from every hospital in the state that does knee and hip replacements, and the conversations were on a variety of topics. And one of the topics was really fascinating. It was on the surgeons talking about what is their role as surgeons with regards to accepting patients and whether or not they should be working with patients to wean them below that 50 milligram dose level. As you can see on the slide, subsequently they issued opioid use guidelines and protocols for weaning patients to lower dosages. And they also are collecting increased data in these clinical registries so they can develop quality improvement programs. So between a variety of these CQI efforts, in fact, 11 of these CQIs are working on a 5-year program with the Michigan Department of Health and Human Services, as well as Michigan Medicine or University of Michigan on a program called Michigan Open. And on that note, I'm going to turn it over to Dr. Englesbe.
Great, thanks, Tom. So I'm a transplant surgeon, and actually my disclosures first. Those are my disclosures. I'm a transplant surgeon, and I got interested in this problem about 3 years ago. As a transplant surgeon, we spend some amount of our time going and procuring organs for transplant, and I kind of became, I guess, impressed by how many beautiful kind of people in the Midwest were dying from overdose, and we were procuring organs. The transplant business, we've done more transplants this past year than we've ever done in the United States, pretty much fueled by the opioid epidemic. But certainly it left an impression, and within that context, we are lucky enough here to live in Michigan and have great partners like BlueCross and BlueShield and our state Health and Human Services to support efforts I'm going to talk about here briefly. So who do we prescribe for? So I'm going to take a very much a acute prescriber perspective. So we tried a lot of work around weaning chronic opioid users before surgery, and it's really, really hard. And as surgeons, we kind of go for easy. So we focus on patients who are not on opioids or intermittently take opioids, and how can we prevent them from becoming new chronic opioid users. So who do we write for now? Nationally, when people come in for acute care, about 8% are chronic opioid users. The rest are kind of intermittent or opioid naive. And our general kind of conceptual model is that the opioid epidemic in general is fueled by opioid naive patients turning into chronic opioid users, either after dental care, surgical care, emergency care. And if you ask kind of heroin users, there's a lot of good data, and people who've had overdose, a lot of good data that they go back to their first dose of opioids, and that usually is done I think about 88% of those happen in acute care. They get opioids and it changes their life. So that's our conceptual model, to try to prevent that from happening, both to kind of reduce chronic opioid use, but also to impact our communities with diversion. So most of the leftover opioids in our communities come from acute care, unused pills, and I'll talk about that in more detail. So why do we write for so many opioids? We as surgeons write for a lot of opioids, and as data will show, our patients use a relatively small number. There's thought that we do that to kind of keep our patients happy, and this is a paper, I'll go through these quickly, but this paper shows that kind of HCAHPS pain scores have no relationship with how many opioids patients receive. So that doesn't seem to be why we write for so many opioids. The other one is to prevent refills. So I'm going to write them for 50 pills because I don't want them to call me on a weekend. This data shows the probability of refill stratified by how many pills patients got across the state of Michigan. And as you can see here, and this is people having relatively minor operations, they got 6 pills or they got 60 pills. about 7% call for a refill. And that's been our experience in multiple kind of settings. So more pills doesn't prevent refills at some threshold. I think this is our most important data slide. So if you could pause and look at this. This is 6 papers that our group has written that really identify the concept of the new chronic opioid user among the chronic, previously naive patients. So you come in, you have an operation that's successful, and then 90 days later you're still taking opioid pills. And I think it's fair to say for most surgical procedures in the United States, the most common complication is taking an opioid-naive patient and leaving them a chronic opioid user. And obviously that can have devastating implications on the rest of their health. And this shows different types of operations ranging from major cancer surgery down to pediatric surgical procedures, and it ranges from 5 to 19%. And I think among the most disturbing, this is adolescents and young adults having wisdom tooth extraction. Common procedure done in the United States. Among people who get opioids after that procedure, about 1.6% become new chronic opioid users. And if you consider how frequently the procedure is done, that is a devastating number for kind of chronic opioid use and misuse. So you come see your surgeon. Everyone knows surgeons don't follow these people long term. This slide shows the trajectory of prescribing, who writes for pills. So between 0 and 3 months after surgical care, surgeons write for most of the prescriptions. But as you can see here, at 6, 9, or 12 months, the primary care providers pick up the prescribing, and we've received that message many times that I send my patient for surgery, and they come back on chronic opioids. What am I supposed to do as a primary care provider? This is that transition of care from acute care to chronic care that I think is so important for us to try to focus our efforts. It's a hard task. Just to put it in context, there are a lot of leftover opioid pills, probably 2/3 to 3/4 of pills that we, at least in Michigan, write for patients don't use after surgical care. So that's about 60 million pills a year in the state of Michigan, or 6 for every citizen. If you put those in the Michigan Stadium, we are at the University of Michigan, that'll fill up the stadium. So most of the opioids within our communities are diverted from kind of acute care or surgical care, leftover opioids. So take-home lesson 1 is new chronic opioid use from opioid-naive patients. Lesson 2 is if you have opioids in your home, you need to get them out of your home. They are the most common cause for home invasion in the United States, and they can have a devastating impact on people around you. So can we improve? So I'll start off with a relatively quick anecdote. This was done actually by a medical student here. And he was impressed by kind of the variation in how many pills people wrote for. This slide shows percent of prescriptions. This slide shows how many pills people were given. The kind of framework here is Norco. And this is after elective laparoscopic cholecystectomy, so taking the gallbladder out laparoscopically, outpatient procedure, one of the most commonly done procedures in the United States. And this is at our institution here in Ann Arbor. And you can see wide variation ranging from 10 pills to 120 pills. About 7, most of the prescriptions are kind of in this 40 range. I think the average is 45. So I'm going to go to the next slide. And this slide shows what patients took. And I left the red bar in here. So as you can see, we're writing for what's in the red bar, but patients are taking the vast minority of the pills we're writing for them. In fact, the median number is about 6 pills, the mean number. So there's a big kind of disconnect between what we as acute care providers write for and what patients take. Now, there's going to be some patients that take all of the pills every time, and that's a different issue. So we just came up with a recommendation. All right, if the average patient's taking 6 pills and we're writing for 45, let's just write for 15 for everyone and give around-the-clock Motrin and a lot of work around patient education. Surgery hurts. It should hurt. Take your Motrin, take your ibuprofen around the clock, and just a little experiment we did. As you can see here, I think it's fair to say when you can change practice pretty easily within your institution if people know that it makes sense. So this is the number of pills we wrote for after laparoscopic cholecystectomy at our institution, and then we had a little in-service, and this is where it went thereafter. So it changed on a dime to essentially everyone gets 15 pills. Refills didn't change. Patient-reported outcomes, so we're still caring for our patients, really important issue. And patients took fewer pills. So basically, if you give patients fewer pills, they take fewer, and we've shown that on several kind of occasions. If you give them 40 pills, they're going to take more. If you give them 10 pills, fewer. So what we have in Michigan with this partnership with all of these CQIs, really supported by BlueCross and BlueShield and the value partnerships that Tom discussed, and the State of Michigan Health and Human Services, is we have a network where we collect data from patients, we figure out how much they're taking, and how much they're written for, and is their pain adequately cared for. And it's a cycle of continuous data feeds where we can come up with precision prescribing recommendations. So these are our first set that came out in October. This is what we recommend in the state of Michigan you write for after these common surgical procedures. We aspire to have this list have 100 operations, and we think these numbers are going to significantly come down as we get more and more patient-reported outcome data. This is how we're driving change. This is the network partners, particularly Blue Cross and the state of Michigan, and all of these physician groups where we are essentially rolling out these recommendations. Similar to the CDC kind of recommendations for primary care providers, these are recommendations. Every patient needs special care, of course. Another focus of our work is pill drops. We're trying to get rid of pills in our communities. We sponsor these with lots of great partnership. We had 9 sites in October. I think this is our 4th cycle of doing these. We got over 900 pounds of pills out of the community. The vast majority come from previous surgical care. So this is my final slide. Our goal is precision opioid prescribing. Some of that involves kind of deep science and trying to understand the relatively small number of patients that really struggle with pain after surgery. But for the majority of patients who are opioid naive, we do think a pathway towards chronic opioid use and abuse is acute prescribing, and our goal is preventing that through precision prescribing. So I think actually I have one more slide. So we are a service of Blue Cross and the state of Michigan, the University of Michigan, and all the hospitals in the state of Michigan. We view ourselves as a public service. We have a large, robust group that knows a lot about opioids. We have broad areas of impact, and just this shows just some of the patient-facing, provider-facing, hospital-facing materials that we have that we'd be very excited to share with anyone who wishes to take a look at them. So here's our contact information. We appreciate the opportunity to engage on this webinar.
Great. Thank you both so much for sharing this important work. It's really interesting to learn about your unique and collaborative approach, and really appreciate all the research that you're sharing as well, which I think is really helpful to people tuning in. We'll turn next to hear from our 2 speakers from Tennessee and their approaches. We'll hear first from Dr. Andrea Knight, the Corporate Pharmacy Director for BlueCross BlueShield of Tennessee, and then from Christina Clark, a Project Manager for Count It, Drop It, Lock It, and a Grants Management and Sustainability Consultant for the Coffee County Anti-Drug Coalition. Andrea?
All right. Good day, everyone. Again, I am the Corporate Pharmacy Director for BlueCross BlueShield of Tennessee, and just some brief tidbits on where BlueCross BlueShield of Tennessee stands. We are a nonprofit independent licensee of the Blue Cross Association. We are the largest health plan in the state of Tennessee with approximately 3.4 million lives, servicing the Medicare, Medicaid, and commercial space. And provide health benefits to approximately 11,000 companies that are primarily headquartered within the state of Tennessee. In terms of where Tennessee stands in this opioid crisis, Tennessee ranks 3rd in terms of opioid prescribing, and for those who like to ask, Alabama is number 1 and Arkansas is number 2. This is actually an improvement over last year, where Tennessee ranks number 2 in terms of prescribing. Tennessee is also 7th in the U.S. for overdose deaths. In 2016, more Tennesseans died of drug overdose than in terms of roadway fatalities, and the spread between those numbers, surprisingly, is less than 700, but nevertheless more overdoses than roadway fatalities. More than 1,000 babies were born with neonatal abstinence syndrome in Tennessee in 2016. This is an increase over 2015 data. Statistics have shown that more than half of those who are using prescription drugs recreationally got them from a relative or friend. So this really speaks back to, get the excesses of medications out of the home. And also what's unique with the state of Tennessee is that we border 8 states. I think Missouri is the only other state that has that many bordering states. And this is significant because this really adds to the complexity in terms of law enforcement and coordination of data exchange. For example, 2 of the border states around the state of Tennessee do not have yet fully operational controlled substance database and monitoring solutions. So this really does add to the complexity in terms of how you manage this across many state lines. BlueCross BlueShield made the decision as a company a little over 2 years ago to really focus and develop a multifaceted approach and to be an active part of the public health solution in terms of the opioid crisis, especially within the state of Tennessee, because that is our home ground and also that's where we have the most impact. There are 3 primary key pillars here, and I trust that everyone here can read, but we want to make sure we encourage the appropriate pain management while also reducing the risk for member addiction, overdose, and deaths. We want to make sure we build our policies and procedures carefully because we want to make sure and reduce the risk for the overdose, addiction, and death, but we also want to make sure that those who truly do need the medication have access to it. And then our third pillar is really to ensure we complement other efforts that share the same goals in terms of prevention and addiction treatment. Our strategy, although seems fairly simple here, actually took quite a bit of time, but here are the tenets. We conducted an in-depth review of current guidelines from various agencies, and this includes even the CDC, the Tennessee Department of Health, and we primarily focused on guidelines surrounding chronic pain. We took a look at what industry-level limits and authorization requirements were within the region as well as in the nation, and we compared those to where our limitations and requirements were within BlueCross BlueShield of Tennessee. Most importantly, we convened an external advisory panel, and the goal was to really get their feedback and have them assist us in development of a stepwise approach on how we do our part to help manage the opioid crisis. And this external advisory panel consisted of a variety of specialties, physicians, pharmacists, other clinicians in the area of pain management, obstetrics and gynecology, hospice and palliative care, as well as psychologists. One of the things that we did once we had a developed plan was then look at communication plans. How do we take this messaging and these activities out to the 3 main areas as we saw, the prescribers, the patients, and to the public? So we developed a communication plan there. We obviously executed the changes in coverage requirements, and I'll get into some detail on that. And we provided philanthropic support for awareness and community intervention. First up, our policies. In terms of formulary, because oftentimes that can be the quickest and the simplest, at least from a pharmacy health plan perspective, on where you can make changes. I can tell you that our primary goal was to make sure that we still allowed access to care, but yet reduce the risk for addiction and overdoses. In 2016, we modified and expanded our quantity limits on opioid medications, and really it was to align with the minimum industry standards. So it was our first step. We also began requiring prior authorization for patients who were new starts to long-acting opioids. Our criteria was based, again, on primarily CDC guidelines, Tennessee Department of Health, as well as significant amount of feedback from our external advisory panel. In 2017, we stepped the requirements up, began requiring prior authorization for all members receiving long-acting opioids, even if they had been on them previously, and we modified our quantity limitations for both long-acting and short-acting opioids, really focused on the cumulative amounts of opioids across all prescriptions in terms of the morphine equivalent dose. Specifically, we placed a limitation across all opioids at the 200 mark. What were our results? In 2017, we completed a little over 18,000 prior authorization and quantity limit requests. The average approval was a little over half at 55%. There was a notable 6% reduction in opioid claims, 10% reduction in the average morphine milliequivalent dose, Primarily, or most of this reduction was in the long-acting opioid components. In terms of practitioner feedback, as you can imagine, it was mixed. I can tell you that there was initial frustration with the changes in the prior authorization requirements, even though we tried to get our communication months in advance of any policy change, and we even began accepting requests several months in advance of any changes. But even despite that, there was some general practitioner frustration with the process, just knowing what documentation was required. We did see a bump in promotion of short-acting agents because of the process. That eventually evened out as, again, we had the quantity limits applied with the total morphine milli equivalent dose. We did encounter just the outright lack of desire to taper members off their opioids, but we also received some very supportive and complimentary comments from practitioners because they felt like it removed the burden of saying, quote unquote, no, off of them and over onto the health plan. Policy changes alone obviously can't address the crisis, though. In terms of how BlueCross BlueShield Tennessee was able to support patients, we developed a well-integrated approach to case management for medical and behavioral health benefits, and really stratified and took a look at identifying those who were the highest risk. In particular, we developed a specialized approach for expectant mothers. This was identified because we experience has shown that the opportunity for intervention while the new coming mother is pregnant, they're oftentimes very motivated to get clean for their newborn or even for any children they have already. And lastly, we also supported collaboration with several state agencies that particularly focused on infants born with the neonatal abstinence syndrome. In terms of providing prescriber support, a majority of our efforts really were tied to partnership that we established with an external vendor. This was a vendor that specializes in care pathways and education for prescribers in the area of opioid use and abuse. It's a vendor that has a variety of mixed specialty expertise. They maintain the largest database on opioid use, as well as the compendium of pain treatment and medication literature. The most effective part of this partnership was the scorecards that were sent out to our network practitioners that really showed, and they were sent out on a monthly basis. Of course, there was a minimum criteria of how many opioids were prescribed, just so we have good data to share with our practitioners, and really was an evaluation of their opioid prescribing patterns compared to network peers. There's also a component here that identified if there were any of their associated patients that may be at increased risk, such as those that may have had either past or present substance use disorders, concurrent use of sedatives, perhaps a past diagnosis of sleep apnea, or even if they're receiving opioids from other practitioners. This vendor provided guidance and consultation on treatment plans on a one-on-one basis, as well as support in terms of clinical pathways. Another portion of our effort was, and this is gaining traction even heading into 2018, was providing some education and training for our emerging practitioners, our emerging prescribers. Examples are chronic pain and addiction curriculum for our residency programs at some of our universities within the state, as well as providing some information and best practice forums for nurse practitioners as well as physician assistants. The third audience, if you will, in terms of community investment, BlueCross BlueShield Tennessee Health Foundation has committed to a substantial investment in Count It, Lock It, Drop It, which I will let Ms. Christina Clark give you plenty more details on that following. There's also, we've committed to $250,000 in foundation grants to law enforcement, particularly supplying either naloxone training or naloxone kits themselves. And also more foundation support for those treatment centers across the state in the area of addiction treatment. And this is a variety of organizations, those that are focused on neonatal abstinence syndrome, inpatient, outpatient treatment programs, as well as even halfway houses to get those recently out of treatment back into society. Also not mentioned here is our public awareness campaigns. We partnered with a number of media outlets in terms of ads, PSAs, and promoted other campaigns such as the National Drug Take Back Days. In terms of where we're going and where we're looking for our next steps, first and foremost is we are going to reconvene our external advisory panel in 2018. That meeting is coming up here in a couple of weeks. We're going to first give them a report back of what we've observed so far in 2017. And some things we're going to look at is there opportunities to tweak our utilization management strategies? You know, do we go down on our required morphine milli equivalent dose? Do we look at shorter quantity limits on day supplies for the short-acting opioids? Are there system edits that we can take a look at that may help and support, such as opioids in combination with other medications such as benzodiazepines, diagnosis codes? You know, currently pharmacy claims do not incur diagnosis codes. Do we have some systematic opportunities there? We've looked at perhaps some outreach directly to patients in terms of making sure they're aware of risk, particularly those who may be new to opioid therapy, and also looking at non-medical offerings. And this is really kind of a wide open because the science may or may not be there to back up some of the what we're calling non-traditional medical offerings. And lastly, we will continue to have our BlueCross, BlueShield Health Foundation support of various agencies. So that is the end of my presentation, and we'll let Ms. Christina Clark share her.
Perfect. Thank you so much. I think waiting to upload my slides. Oh, perfect. Thank you also, and thank you, Andrea. As mentioned, I am Christina Clark, the project manager for the Count It, Lock It, Drop It program, and that is a strategic community approach for prescription drug abuse prevention. For those of you not familiar with anti-drug coalitions, this initiative was born out of the Coffee County Anti-Drug Coalition in Manchester, Tennessee, and coalitions are across the U.S. and abroad as well, and we really are focused on a cultural shift and change. And so one of the things I first want to talk about is, though Count It, Lock It, Drop It is an incredible, catchy PR and marketing, it really is more about, for us, also what's happening at the grassroots level. So it's really important to talk about how we have broken down silos and have this cross-sector involvement as we're working with different states and in the state of Tennessee for prescription drug abuse prevention. So we work with everyone from law enforcement, school systems, hospitals and doctors' offices within this campaign to really build an infrastructure on the local level. Though some of the monies for this program have come from the top down, from whether it's been a federal or state partner, really the work is happening from the bottom up. It's really engaging those individual community members and the doctors and pharmacies in these local communities to start making that cultural shift around the perception and behavior of prescription drug misuse in their communities. A little background on the program, the history of Count It, Lock It, Drop It. As I mentioned, it started in Coffee County, Tennessee, and it really originated around the Drug Take Back program. And this was in 2010 that the coalition started doing this. This was before it took off nationally. And the reason we started doing it was in 2009, we realized that our suspension and expulsion rates in our area schools, one of the #1 reasons was prescription drug sharing in schools. And that was, of course, concerning to us. And so we did a comprehensive community assessment looking at what was happening in Coffee County and realized that the main issues we were looking at was access to these drugs and also the perception of harm surrounding them, particularly around how our adults model behavior around prescription drug use. So we had the Take Back events. They're very successful. And then in 2011, we worked with our evaluation team, the Pacific Institute for Research and Evaluation out of Kentucky, to put on medical professional focus groups. And we invited everyone from nurses, doctors, veterinarians, and dentists to come and start talking about what we could do in our community to make a difference. And they really sat down and looked at what could be done in pharmacies and in medical offices to combat this issue, because what we know is that the community and patients and consumers want to hear prevention messages about prescription drugs from the people prescribing them. They are the authority figures on it. So as important as Coalition and other sector members are in fighting the epidemic, that really the messaging needs to come from these medical professionals. And so we worked with them on developing a program, and the first iteration was really what they could implement within a medical setting and a pharmacy setting concerning prescription drugs and getting messaging out. And so with them, we worked to create what is now Count It, Lock It, Drop It, and I'm going to go over exactly what that messaging is in the next slide. In 2013, we won a national award for our ability to reduce prescription drug abuse in our community. In 2014, we packaged and branded that so it could expand to other counties and states. That was with the assistance of the Tennessee Department of Health and the Tennessee Department of Mental Health and Substance Abuse Services. And then in 2016, we were so excited to bring on our partner, BlueCross, BlueShield of Tennessee Foundation, to assist us in truly having a statewide effort in Tennessee. As I mentioned, the foundation of messaging is very simple. It's to count your meds every 2 weeks to prevent theft and help ensure medications are properly taken. Lock them up, lock up your medications and store them in a secure place where others would not think to look. And drop off your unused or expired medications for proper disposal at drop box located in participating law enforcement offices or pharmacies or take-back events. And as mentioned, when we first were developing this, it's with medical professionals, pharmacists, and doctors sitting at the table. And so they helped develop, particularly the pharmacists, around counting your meds every 2 weeks. They wanted to make sure that it wasn't so often that people were losing their meds and coming and complaining that they were missing pills because they were accidentally dropping them, but not frequently enough that you could just see if someone had stolen any and you could remember who was in your home at that time. A part of this program is we offer lock boxes. Statewide, we haven't been able to do it in a comprehensive way, but we have received monies from Shell Oil and some others to provide them in hotspots areas. Other than that, coalitions and other departments, such as health councils, have helped buy and purchase boxes for their own individual counties for this. So lock up your medications and store them wherever others would not think to look. And then working with law enforcement departments to make sure in pharmacies that there are disposal sites. So the first iteration of the program was working, again, like I said, with pharmacies and medical doctors, where a person would come into an office, and it might be a doctor if it's a practice in which it allows him to do this with time management. It might be an office manager. It might be a nurse practitioner, depending on how the office runs. They would enact a policy change of how they were going to do it and implement it in their office. That when they're prescribed a controlled substance, particularly an addictive one, they have a conversation around the addictive nature of the drug and then talk about the importance of counting, locking, and dropping their pills. If it's in a smaller community, such as Coffee County, a lot of times they have on hand the counting brochures to assist them in the counting and the boxes to provide them at that point. Then they go to a pharmacy and they get the exact same message, because as we know, repetition of message is of the utmost importance. The pharmacy involved, again, has made a policy or procedure change to implement the program at their level of how they're going to do it, whether it's going to be a pharm tech or a pharmacist that has conversations about the Count, Lock, and Drop It program. They come up if it's a controlled substance, or maybe for some of the bigger pharmacies, if it's a new opioid script, they'll have a discussion around the Count, Lock, and Drop It program, the addictive nature, and provide the counting brochures or prescription drug disposal cards or anything like campaign components, so that they're getting that repetition of message. The main initiative goal is obviously to reduce prescription drug abuse in Tennessee right now, and then the objective to reduce access and to increase the perception of harm regarding prescription drug use. And as I mentioned, when we started looking at this, we did do several focus groups and youth and adult surveys surrounding what was happening in our county, and really realized that the issue was that people weren't counting and monitoring the medications, allowing it to be a first place of use, if someone was interested in trying prescription drugs for the first time. They weren't locking up the medications, and they weren't disposing of them properly. So making sure that we were really hitting those three items in terms of reducing access. And then increasing perception of harm. We realize in talking, and this is still an issue today when we talk to parents around prescription drug use, that they're either self-medicating their children. We call it a generation of doctors, too many people web and deem themselves medicating their children because they were prescribed it for a reason, not modeling good prescription drug behavior because they don't either finish their medicine or they're not locking it up or safeguarding it in a way that shows that this is something that is dangerous and should be treated in a very specific way. And there also that we want to educate families on medication safety in general, because what we found was there's very little of it out there. Yes, for someone who has a 3-year-old talking about medication safety, but not thinking about the idea that there's access in your home to what could become a prescription drug abuse problem. And so thinking about past just child-safe caps and really talking about changing a cultural shift around how we treat medicines in our home. And as I mentioned, the first iteration really was just to work primarily with pharmacies and medical offices. And now as we're working forward, we do have a public education piece as well as a school education piece to make sure that we're fully reaching those sectors. As I mentioned, we realize that this is a comprehensive problem that takes multiple people sitting at the table. And so making sure we're bringing in the other ways of educating the parents and students as well as the general public. And so as we were funded in 2016 with the BlueCross, BlueShield of Tennessee Foundation monies, we were partnered with MPNF Public Relations to really get a statewide message out there about Count It, Lock It, Drop It generally and not from the grassroots approach. And so their goals for this was to increase the awareness of the Count It, Lock It, Drop It initiative, increase the number of people who counted their prescription and pain meds, increase the number of people who are aware that prescription medication should be safely discarded at take-back and drop-box sites, and increase the number of people who take their unused opioids to a drop-box. This is the current map of what we look like in Tennessee to date. We actually had a new county sign on today, Campbell County, so we will be filling this in more. We have 66 counties of the 95 involved in the Count It, Lock It, Drop It initiative. This has been great building partnerships and infrastructure. We really sold the program as this is not just, again, us getting the message out, but us knocking down the silos that has really contained us in really fighting this epidemic. So we're working directly with health councils, anti-drug coalitions, state departments like the Tennessee Department of Environment and Conservation. We work with to ensure that every single one of these counties had at least one disposal site, working with local pharmacies and the pharmaceutical associations to make sure that we were working with pharmacies to have sites located in there. So there's really a network of people working with the Count It, Lock It, Drop It program to make this happen. They were all doing it on their own and making concerted efforts, but it's been great for us to come together to really work on policy changes that have made us all on the same page and can really move the needle in the right direction for reducing those overdoses and the addiction issue we're having in Tennessee. So we have continued to grow. In 2014, we started to grow outside of Tennessee. We are in several other states. The only other statewide initiative we have right now is in Rhode Island, and we're in 4 of the 7 regions currently working on Count It, Lock It, Drop It. And we're excited to see this continue to move across the states. And as I mentioned, it really is building the partnerships that we need to leverage the change in each of these individual states and communities as we move forward. And as part of the activities, as I mentioned, we're doing more than just making sure there's PSAs out there. We really are working to train individual communities on how to effectively implement this program and to build a partnership at the local level. So we provide monthly webinars on anything for how to successfully do an evidence-based drug take-back, to how to get your pharmacists involved in providing local on-the-ground TA and support for doing that, getting medical professionals involved, whether it's us hosting a summit or a training at the local level or a webinar. We do one-on-one support for key stakeholders. Like I said, we can send any of our team down to work one-on-one with people struggling, whether they're having trouble with pickup for some of their drug disposals or they're having issues with another agency. And then, of course, we're providing all the data collection and the campaign supplies as well. And we really did the supplies based on population. So a big area like Nashville is not getting just 1,000. We were providing hundreds of thousands of posters, prescription drug cards, promo items, and everything to make sure they could get the word out in each of these individual counties that are based and tagged for them. What's also so important is these have all been localized. So as I mentioned, Pacific Institute for Research and Evaluation is a team of evaluators for this program. They've been with us since 2009, and they've been working on Count It, Lock It, Drop It specifically since 2015 with us. Our end goal is obviously to become an evidence-based program. We are working towards that now, and so we're excited to continue working with them. I know time is short, so I want to provide briefly some of the data. In Coffee County, what we have been able to track and see on a local level from when we won that national award is some significant decreases in what we're seeing, as I mentioned, on the grassroots level. Obviously, those are the 30-day prescription drug use decreased by 25% among our 8th, 10th, and 12th graders. And the other one I want to mention, because it was the reason we started the program, was we decreased reported sharing of prescription drug at school by 50%. And then, of course, we're seeing increased numbers of locking, tracking, and disposing of prescription drugs, which wasn't, at the time, we weren't tracking at all, and so this was the first line of tracking. In terms of state-level data, one of the big things we've seen is the amount of disposal that's happened in the last year. For counties that are involved in CLD, they're seeing on average 50% more than other counties that aren't involved in CLD, and so we're really, truly seeing more disposal happen in those counties. And one of the things we do differently than a lot is we track the controlled substances at many of these sites to see what we're getting, and we are getting a substantial amount of oxy, Xanax, hydrocodone, and those things at these events. And as I mentioned, our partner MPNF also working towards the public awareness piece. With their focus group surveys, they've been able to see that, yes, the word is getting out there. We're seeing that 72% of people, 14.3% increase, are of people counting their prescription pain meds, also a 14.3% increase in the amount that are aware that their prescription medication should be discarded at take-back boxes. And a number of the people who take unused opioids to a drop box, we're seeing that there's an 11% increase in awareness. So we really, truly are seeing a great effort from the PR perspective on this. And then finally, if you have any questions or would like more information, please don't hesitate to reach out to me. I also provide NIHCM with our brief evaluation report from 2017, that is available on their website if you are interested in seeing more of the data from the program. And I just appreciate your time and attention today, and thank you so much.
Thank you, Christina and Andrea. Our final speaker is Dr. Dave Thomas, a health scientist administrator at the National Institute on Drug Abuse, and we're so excited to have him with us today to share his work on NIDA's pain and opioid research. Dave?
Yeah, hi, it's Dave Thomas. Thanks for the introduction. Thanks for having me as part of this meeting. I'm going to keep it quick, keep it short. We're running late on time, so I'm kind of like less is more, I think we should take as an approach here. So nothing to disclose except I care about people in pain and also care about the opioid crisis. We at NIDA do both of those things. My talk's going to follow. I'm just going to go over how pain works and how addiction works real quickly and how they kind of intersect. Then I'm going to touch on a few of the things that we're doing at the NIH to address these problems. I don't have a lot of slides on that, but I'll just talk through some of that. And then I was asked early on if I knew anybody that could talk about alternatives to opioids, and the VR, virtual reality, came up as a possibility. And it's like, well, I've been promoting that at the NIH for the last 18 years. So I'm going to end with just zooming in on one potential alternative to opioids. So, but first, how the brain and pain work. So here's a brain. We're looking into there, and pain comes up into the brain and can cause the brain itself to get inflamed, can be perceived as pain. It goes up in pathways. But what happens is you have endorphins in your brain, and they get released, and they activate descending control of pain, and that can then reduce the pain. Sorry, I'm working on my animations here. This might be too complicated for this. So that's all fine and good. But then the way that that opioids work is they mimic the effect of your endogenous opiates. They get released in your brain. They can activate your descending control systems of pain, and they can result in the pain going down. So that's wonderful. But the problem is when you give an opioid systemically, if you take a pill, it goes all over your brain. It doesn't just go to the parts that stops pain, but it goes all over the place, and it goes to places that are involved with addiction. And separating out those two is a key thing that we're working on, but is very difficult to do. And so you basically have two parts in your brain. This is real simplistic, but your prefrontal cortex can stop addiction. It's your brake, if you will. But then you have your limbic system that's kind of your go system. And when that gets opioids, it gets overactivated. And the part that stops your addiction, your prefrontal cortex, that's your impulse control, that gets minimized. So it's basically driving around with the accelerator down and no brakes in a car. So that's what we're trying to get at, and trying to find a way to reduce pain without activating this whole stop-go thing where a person gets out of control. So now let's go to a question. How many people in pain become addicted? I mean, this has puzzled us for a long time. I've seen reports anywhere from nobody or almost nobody, and that's part of the problem, to something like 40%. We just don't know. We don't have those studies looking at people transitioning from pain to addiction. We're starting to do research in that area. We're also working with the FDA and Pharma to look at this question prospectively. If you have pain, you're not addicted, you start taking opioids for pain, do you start misusing? Do you abuse? Do you become addicted? Do you die? Do you actually have more pain as a result of getting the opioids? It's called opioid-induced hyperalgesia, and we think that might be part of the problem we have in America right now. So that's one set of studies we're looking at. I'm going to show some CDC data. You've probably seen them, but I think it's amusing and intriguing and disturbing all at the same time. This is the death rates in the United States in 1999, and you can see as we progress through the slides how things digress in our country, where there's more and more red, meaning more and more people are dying from opioids. And this trend has been getting worse and worse and worse. And when I ran this analysis, I threw in the 2016 data, which I haven't seen, but you can do it through the CDC site, and it was shocked because the red went down. It's like, oh my gosh, this isn't consistent with the data we've seen in terms of the increase in rate. Well, what they did, if you look down at the bottom, they changed the scale. So red now means 30 or above, not 20 or above. So not only is this not promising, they had to expand the scale because of the scope of the problem. So the problem is continuing. This slide was shown earlier in three waves, which I thought was a real intriguing way to do that and informative. But this goes out to 2016, so you can see the fentanyl is now the leading cause of opioid deaths, and heroin spiking up too. Fentanyl, 100 times stronger, 50 to 100 times stronger than heroin. It doesn't take much extra fentanyl to die. It just if you look at carfentanil, that's about 100 times stronger than fentanyl. So part of the problem is people are using heroin. It gets laced with fentanyl, which is relatively cheap to make, but if you get a little too much, you're dead. So if you look at, and this is SAMHSA's data, but this is transition from prescription opioids to heroin. 4 out of 5 people that start abusing heroin started with prescription opioids. It's prescription opioids is a clear step in the process. Not that they're in pain or the pain patients, but it certainly is part of the problem. And if you look at the opposite direction, 1 in 100 start with heroin and move to prescription opioids. That trend might be changing, by the way. There's some newer reports that more people might be starting with heroin, which we have to keep an eye on. But if that's true, there's another problem we have to deal with. The next slide, again, is just showing the data from the death rates from opioids. But then I superimpose how many people in the United States had pain, chronic pain, serious pain, daily pain. These are from the American Pain Society, IOM reports. From 1999 to 2011, the number of people in pain in the United States doubled, which is odd because pain, we don't think it's contagious, but there's a pain epidemic expanding, and part of that might be, if you think back to the opioid-induced hyperalgesia, part of this might be people that take opioids for their pain, they get a rebound, which ends up causing pain, and then take more opioids. So for some people, there might be something of a vicious cycle. This is the concept. Short on time, don't want to get into it too much, but this is the science. It's called a polarity behind what we think about that proverbial pendulum swinging. These swings are natural in society and life and business and religion, but back in the 90s, we were really pulled away from doing opioids, and then a bunch of factors pushed the pendulum way too far for the use of opioids and the overuse of opioids. Now the pendulum's swinging the other way, and what we're doing at the NIH, I'm going to stick on this slide for a couple minutes, is trying to make sure that as the pendulum swings back, we both help fight the opioid crisis, but we also help people in pain and have them not crushed by this pendulum swinging back. Now, just a few things we're doing at the NIH around pain and opioids. We're trying to first treat both of these problems together, not just focus on the opioid problem or focus on the pain problem. We're trying to fight both of them. One thing we're doing through the NIH Pain Consortium is we've created an educational portal for clinicians in training, and that's we call the Centers of Excellence in Pain Education. We now have 7 online modules. We're trying to help clinicians learn more about how to treat pain, learn more about how to treat the potential of addiction that they'll encounter. Is the most common thing that pain is the most common thing that most clinicians will encounter in their work. Right now, the average clinician gets about 9 hours of training on pain over the course of 4 years of medical school. We're trying to make that better. We also have a national plan. It's called the National Pain Strategy. It came out. It was released the same week as the CDC Guideline. I was involved with the development of the CDC Guideline, but I also helped develop the National Pain Strategy. If you think of that, the CDC Guideline, it's saying, for the most part, use less opioids, use them more reasonably. But the National Pain Strategy is saying, okay, well, you're using less opioids, but here's these other things you can do. And a question came in about acupuncture and things like that and barriers to that. We got to break down barriers to these non-opioid treatments. We got to get more reimbursement for those things. A big event that happened, the NIH now considers the opioid and pain crisis our top priority by far of anything else. It's likened to the AIDS crisis, of the priority of the AIDS crisis that stemming from the 80s. The head of the NIH, Francis Collins, had 3 workshops over the summer, and we're pursuing public-private partnerships where drug companies will work with us, the NIH, trying to do things that will help with the pain and opioid crisis. We have 3 committees working on the pain side. One committee, we're trying to get Pharma to share their data with each other. They're very secretive. I've got this, you got that. And if they work together, maybe we can come up with better pain treatments and be able to rely less on opioids. And Pharma wants to share. There's legal stuff and all that, but they do feel like they should be part of the solution to this problem. So we're developing a pain trial network, and we're also developing biomarkers for pain. Part of our problem in studying anything, the foundation of good science is good measures, and we really don't measure pain well. 0 to 10 scale, verbal report, hurts a lot. That's what they were doing in prehistoric times. So we can do better. Pain is a real phenomenon. It impacts a person on many, many levels, the biological, the social, the psychological, spiritual levels. We got to get some better measures so we can study it better so we can diagnose it better and treat it better. So I'm thrilled. I'm a pain and opioid guy, and I'm thrilled about all of these things happening at the NIH. But then last Wednesday, the head of the NIH called us into this building that you're looking at, that's Building 1, and the pain people from across the NIH came, and he had an announcement that he wanted to do more than the public-private partnerships. He wanted to look at all sorts of other types of pain treatments, all sorts of other ways to deal with the opioid crisis. And he had met with Congress people, and I kind of fell off my chair, but he said that there'd be $2 billion in new money invested to the NIH on this. That's, as a government employee, we deal with $1 million here, $1 million there, and it's a lot of money, but it's we don't usually deal with $2 billion for an issue, and we're thrilled that that's coming up. And right now we're scrambling to use that money to get the money, put it in places that really have impact. So a lot going on at the NIH, too much to talk about in this short talk. I have 4 or 5 minutes left. I would like to discuss one alternative to opioids, and it's just an area being recently developed. It's not the answer. I think the answer is not one thing. But since 1999, I've been interested in virtual reality and pain. You put goggles on, and you go to different worlds. How could that be used therapeutically for drug abuse, for pain? I think there's some real potential. This is a mock-up of this is what I saw on my desk. Somebody literally put this journal on my desk, but I didn't take a picture. I recreated for this talk, but fact still remains. It was that little event started me on a 17-year quest to promote virtual reality and pain. A leading researcher in the field, this is Dr. Hoffman. He's treating somebody with burn pains. People with burns, they have to have their dressings changed on a twice-a-daily basis. It's very painful and it's very disturbing, but they put them in these virtual reality outfits. This is a special one that could go in water, and they don't even notice it practically. So that was one encouraging way to use VR. I'm just showing you this. This is Brenda Wiederhold, a pioneer in the area. This is an old head-mount display to see virtual reality set up. It literally has to be held up with a rope. It's heavy. This was 15 years ago. We've come a long way since then. In 2004, we had our first conference on VR at the NIH. That was interesting because we were bringing, at the time, very weird science to the NIH and trying to bring it into the mainstream. There's a number of different ways to use VR. I'm just going to scroll them because I don't have time. But things like you could do meditation in VR. You can use distraction. You could use cognitive behavioral therapy. You can learn coping skills. So all those sort of things can be included. And the big advance, and I'm not promoting any given product, but right now these head-mount displays, they're cheap. They used to be $40,000, and it was hard to get one in a clinic. Now they're $300, $700. I've got one in my basement, and the Olympics are in VR right now. I haven't gone down to look at them yet, but it's becoming much more accessible, mainstream, affordable. So I think now might be a really good time to keep pushing this field forward. And it always helps when the director of your institute is interested in what you're doing. This is our director in VR last year, kind of very interested in the world. She's very much promoted. It's Nora Volkov. She very much promotes technologies. And then I just want to tell you something about funding. Here's where we were, and these are how many grants were funded in 1995 at the NIH on VR, 2003, 2010. It's really been skyrocketing. So, and in terms of dollar amounts, we're spending a lot of money on this, and this isn't the only thing. We're not spending $2 billion on this, but we're spending a lot of money, and it's across a lot of the different agencies. So this is almost my last slide. I was hoping I'd have a minute left to say one more thing, so you get a bonus slide, if you will. So we're very concerned about opioids, very concerned about pain. But at NIDA, we take across drug abuse. We're not the National Institute on Opioid Abuse. We're the National Institute on Drug Abuse, and we're concerned about other drugs of abuse. So cocaine, if you look at the death rates, this is a paper we just published for African Americans versus whites. African Americans are dying of cocaine at the same rate that whites are dying of opioids. So it underscores that we don't just have an opioid crisis. We have a drug abuse crisis, and we got to fight on all fronts. And that is my last slide. Thank you.
Thank you so much, Steve, and thank you to all of our speakers for these incredibly rich presentations today. And unfortunately, because of all the great presentations, we did run out of time for Q&A, but we do appreciate the audience's questions, and we do have your questions and contact information, and we'll share those with the speakers so that they might be able to answer some of the questions that are specific to their presentations. We did have a lot of questions come in about medication-assisted treatment and other aspects of treating opioid abuse, and we do want to let you all know that NIHCM will be convening a webinar to focus more on treatment and preventing overdose, and that'll take place next month in March, and you'll should all receive information about that. We'd also like to share our infographic, The Opioid Crisis at a Glance, with you all, and also ask you to take a moment to share feedback from this event and complete a brief survey that's on your screen right now. So thank you all again to our excellent panel of speakers, and thank you all for joining us today. You can access the slides, and an archive will be available on our website shortly. Thank you.